Thank you very much. It's great to see a full house here today. Very excited to hear that we have 1,200 people across the three prairie provinces. It's great that we can get this information out there on a large scale. First off, I'd like to thank the Arthritis Society for allowing me this privilege to be able to speak with you today. In particular, Deb and her team here in Saskatoon. We've been involved in numerous events with the Arthritis Society, and it's always great for us as a clinic as well as a profession to be able to get our message out there. So pain. Pain is something that we all experience to different extents. There's quite a different experience of pain from us. Dr. El Gabalawi referenced this. We're going to speak a bit about it. There's lots of different treatments for pain. The one I'm going to speak about the most today is exercise and how that relates. We're going to touch a little bit first on some of the different sources of pain, and then we'll relate the exercise to how can we address these sources of pain. So, as Dr. Gabalawi alluded to, there's a few different ways that pain can be produced within our body. The first of these is something that we call nociceptive pain, and even within nociceptive pain, there's a few different subgroups. We're going to talk about just a couple of them in particular, the mechanical as well as inflammatory pain, and in particular how they relate to osteoarthritis and rheumatoid arthritis, as those are two of the more common ones that we deal with. Second one we're going to look at is something that's called peripheral neurogenic pain. We're not going to talk a lot about this today. I'm going to expose you to it because it is a type of pain that's heavily involved in a lot of the chronic pains that are out there. Can be very difficult to treat. I thought I would touch on it today, but as far as the exercise component, we won't focus on it as much as we will some of the others. Central sources of pain, again, Dr. El Gabalawi touched on this. This is often referred to central sensitization. This is how our brain and our spinal cord can start to produce pain or sensations of pain, even in the absence of an actual stimulus. If we don't have somebody poking us with a pin, but we're still experiencing pain, sometimes it's because of those central systems in the brain and the spinal cord that can produce that pain. And then there's many other mechanisms. These will relate to things like our endocrine system, our cognitive function, et cetera, et cetera. There's all kinds of different processes that go on with the body. So realizing that it's not just the inflammatory process, it's not just the mechanical process in a joint, lots of different things can produce pain in the body. We're only going to touch on a few of them today. So first, if we look at the nociceptive pain, I said the first subgroup we'll talk about is the mechanical aspect of it. In osteoarthritis in particular, what tends to happen is that the articular cartilage within the joint starts to wear a bit. We can get some cracking within the cartilage, and then eventually it can lead to the two bone ends actually contacting each other. And then quite often you'll hear people talk about the bone-on-bone aspect that can happen with really severe osteoarthritis. And bone has a ton of nerve endings in it. And so when we start to get that bone-on-bone contact, it produces that mechanical pain. It's why it hurts so much when we break a bone. It's that high concentration of nerve endings within the bone can lead to that mechanical pain that we feel as the two bone ends start to compress and push on each other. We can get that pain from the nociceptors within the bone. So there's a pretty good picture of it. On the left is a normal knee joint. You can see the nice white rim of cartilage lining each bone and the space between it. And that space is critical, particularly in any of the weight-bearing joints like the knee, the hip, the ankle. We need to have that space within there. The purple within this diagram represents the synovial fluid. That's normal fluid that's within our joint that helps with the lubrication, so that those bones can slide on each other. They have to be able to twist and slide and move without any friction. And that synovial fluid helps lubricate that joint. On the right, if we look at an osteoarthritic knee, probably the big difference you can see is we don't have that white lining on the ends of the bone anymore. That's as that articular cartilage has degraded and isn't present as much as it is in a normal knee. and in particular the space, that space is gone. And that's where we start to get that bone-on-bone contact. We don't have that space anymore, so we don't have any cushion between those bones to absorb any impact, any compressive force at all. As well, there's no space really for that fluid to get between the two bones and provide that lubrication. So part of what we focus on with the exercise component of it is ways that we can assist with that lubrication and at the same time see if we can create a bit of a hydraulic effect where we can use some of the muscles and the other structures around the knee to create a little bit of a lift where we can try to improve a little bit of that space. And I mean, it's millimeters, but it's enough where we can allow some of that fluid to get into there. And we'll talk in a few minutes here about how that actually affects the cartilage within the joint. Now, what will also happen if we were to look back at that slide I just had on there, as that joint space starts to lessen and those two bones move together, on the sides and on the front and the back of most joints in the body, we have ligaments. And the ligaments are the structures on the outside of the joint that help us provide some stability. As that joint space decreases and those two bones start to move together, those ligaments are going to start to buckle a little bit. They're going to start to slacken off. They're not going to have the same amount of tension on them as what they used to. And so now we get a joint that becomes too loose. And if you can get it bad enough, you've all probably got that knee that'll clunk a little bit as you move, and particularly if you twist. Sometimes in the fingers, we'll see this too, that the bones start to slide around a little too much, and we start to get that clunking, cracking, some of those types of sensations as that joint starts to become a little bit too loose. So your body recognizes this. It starts to try to compensate for it, and the muscles will tighten up to try to stabilize that joint. In theory, makes great sense. The muscles try to take over the function of the ligaments. Problem being is that muscles can also produce pain. And so as those muscles start to tighten up, now we can get a mechanical pain from the muscle as well as a mechanical pain from the joint. So we can get our bone-on-bone contact, so we can get our bone pain. As those ligaments start to get extra forces or torque on them, we get a ligament pain. Again, ligaments have a lot of nerve endings in them. That's why it hurts so much when we sprain a joint. And now we can get muscle pain. So we can start to get multiple sources of pain, all from the same process happening in the joint. What the muscles will also do is that most muscles in our body go across a joint. And so when they tighten, they can add to that compression of the joint because of that, because of them going across. And they can start to limit the joint mobility. And we've all found that where, we find that after we stretch a little bit, we can move better, and that's as we can release some of that tension on the joint. And so it's not only the muscle tension, but again, it just allows those bones to move a little more freely on each other. Now with rheumatoid arthritis, it's a little different process that happens within the cartilage and within the bone. And what can happen with rheumatoid is the actual bone itself can start to erode. As the cartilage erodes, the bone itself can start to erode, again, which can be quite painful. Anybody who's dealing with osteoarthritis can certainly attest to that. And we can start to get that deeper bone pain along with an inflammatory process that happens. So we get our mechanical pain, plus we can get an inflammatory pain. So what will happen with the inflammatory pain is it's chemical. And what happens is that synovial fluid that I talked about there earlier, there's a lining inside your joint called the synovial membrane. And that membrane's always constantly producing that synovial fluid. Now, what can start to happen in some of these inflammatory conditions is that we get some of these chemical mediators released, and they create a bit of a toxicity within the fluid where it can create that chemical pain because of some of those chemical mediators that are being released. These mediators that released then can start to produce swelling. And now we get the swelling because of an inflammatory process. Because it's a closed space, as the swelling increases, it can't go anywhere. It's only got a certain amount of expansion that it can do. And so it starts to fill that container, and it creates pressure inside the containers. Just like you pump your tire up with air, it can only go so far. And as we start to create that pressure within the joint, now we get that mechanical pain, because there's a capsule that surrounds the joint. There's those ligaments we talked about, And so as that swelling increases in the joint, it starts to create a pressure on those ligaments, on that capsule. So now we get our inflammatory pain because of those chemical mediators that are released, and we get the mechanical pain because of the pressure or that hydraulic effect that has happened within the joint. The swelling can also lead to a lot of stiffness. We're not able to bend that joint as much as we used to be able to. And again, now we start to get those multiple sources of pain within the same joint. So with rheumatoid arthritis, this is often what it'll look like within a joint, and it quite commonly affects the hands, commonly affects the feet. If you can see in the picture there, the joints start to get swollen, they start to get red, and that's because of that increased fluid and some of those chemicals that are released, and they create a lot of warmth within the joint. So the joints will often be quite warm, if not even hot to touch, because of those inflammatory mediators that are released. And the small picture on the right there starts to show how we can get some of that swelling within the joint, really starts to create that pressure inside the joint and can lead to a lot of that mechanical pain. Now, the next one we'll look at is the peripheral neurogenic pain. Like I said, I'm not going to touch a lot on this, but I wanted to expose you to it because it's an ever-emerging source of pain, particularly in chronic pain. We're starting to find this with a lot of folks. When we look at the nervous system, we have the central nervous system, which is the brain and the spinal cord, and then we have the peripheral nervous system, which is everything outside of the spinal cord. So these are the nerves going to your arms, to your legs, to your trunk. And normally, in most instances, those nerves just carry an impulse. All they are is just a transport vehicle. They just carry an impulse. What can happen with different conditions, arthritis included, is that now these nerves, for whatever reason, they start to actually produce pain. And what we can find along them is this term, what they'll call abnormal impulse generating sites. And so instead of just carrying a sensation, now they'll actually start to produce it. Like I said, we won't go into a lot of detail about this today. It's a fascinating area of pain, and in particular, chronic pain. The exercise component we're going to talk in a few minutes deals with this as well. So I'll leave it at that for today. If anybody's interested more in it, please come chat with me afterwards, and we can certainly cover a little more detail. Central nervous system pain. Dr. El Gabalawi touched on this with the central sensitization. This is where the brain and the spinal cord can start to produce pain, even though they're not the ones being directly affected. And so there won't be an actual stimulus at that moment, but then it can start to produce the pain. So, for example, these are some of those pains where you're just sitting at rest, and all of a sudden you get this sudden jab of pain. Different than, if you're aching and stiff at rest. It's more just that pain that seems like it has a mind of its own, where all of a sudden randomly you'll get this shot of pain in your knee or this shot of pain in your hand. And a lot of that's more to do with mechanisms within the brain and the spinal cord, where we're getting pain nerves firing when they're not supposed to be. This source of pain, this central pain, can be heavily affected by what we think as well as what we feel. Because of the brain involvement, it can have a big effect on it. An example of this would be two different instances where, for example, if you were to stub your toe. If you're having a really terrible day, nothing's working out the way you thought it would be, all of a sudden you stub your toe on your chair, it's going to hurt, and probably going to hurt a lot. Compare that to, you're playing with your grandkids, you're outside, you're having fun, you stub your toe, it's probably not going to hurt as much. Might be the same stimulus, but our experience of it can be very different because of the state of our emotions and our mood at that time. And that's where the central nervous system, in particular the brain, can have a large effect on how we experience pain, even though the actual stimulus that produced that pain is the same. And I think we've all found this, sometimes things just hurt more than they should, or more than they did the day before, more than they did a year before. And so we always have to be cognizant of that central aspect of pain, because it can be a big effect of it. Now, as I mentioned, there is lots of other sources of pain within the human body as well. these must be managed as well if we're going to be successful. Again, Dr. El-Gabalawi touched on this a bit, that there's lots of other systems within our body. There's the autonomic system. This is our fight or flight system, or calm, this is versus adrenaline versus no adrenaline. Can have a big impact. Lots of folks who've just been in a car accident, for example, don't really experience pain at the time because of everything else that's going on and the adrenaline rush that their body goes through. A few hours later, or the next day, it feels like they've literally been hit by a truck. And that's as the body finally has a chance to process it. The neuroendocrine system, same thing. We have that adrenaline release that can certainly affect the pain that we feel. Our immune system has a big effect. If we're sick with the stomach flu or we have a really bad cold, again, sometimes that knee may hurt more than it did the week before when we were feeling great. As that immune system becomes depressed, then so too does the experience of the pain gets affected along with it. Now, where the cognitive part of it comes in is particularly with chronic pain or some of that arthritic pain we've been experiencing for months and years, we start to get that belief that it's harmful or it's disabling. And in the physiotherapy world, we talk with clients a lot about this of hurt versus harm. And in particular, when we're doing exercises with folks, we always have the discussion that there's a big difference between if something's going to hurt a bit or if it's actually going to be harmful and cause damage. And this becomes really important with our daily activities as well as with any exercise, that we have to be comfortable in knowing that a lot of the stuff we do is not going to be harmful. And we'll talk in a few minutes about education. And this is where the education component is so important, that you need to understand the disease, understand how it's affecting your body, and then that'll help you understand when something hurts, is it being harmful or is it just being hurtful? And so we want to really be able to differentiate between the two. Because what that can lead to is fear avoidance behavior, where I don't want to do that activity because I think it's going to hurt. And then we end up doing nothing, or we just rest, which, as we'll talk about, is definitely not productive and can actually make things worse. So that fear avoidance, very, very common. Nobody likes pain. Nobody wants to go through pain, and so sometimes even the anticipation of it can be as disabling as the actual condition itself. So Dr. El-Gabalawi touched on the visual analog scale. As you mentioned, pain is very difficult to measure because it's such a different experience from person to person, very different from men to women, children to adults. And so we've come up with the visual analog scale, which is a 0 to 10 scale. We get you to mark on a line where that pain is out of 10. 0 being there's no pain at all, 10 is as bad as it possibly could be. I'll throw this slide back up in a few minutes here, but when we're looking at activity or exercise, we always want to try to stay below 5 out of 10. So 0 to 2, very safe, it might be a little uncomfortable, nothing too bad. As we move into that 2 to 5 range, it's starting to get a little more intense, but it's still acceptable. We've got some soreness, but it's not going to be that debilitating pain. Chances are it's not going to bother us too much the next day or a couple days later. Once we start getting past 5 out of 10, then we've got to really evaluate what we're doing and whether we need to modify the activity that we're doing or whether we need to do something along with the activity, whether it's any of the medications, braces, those sorts of things to help us modulate that pain, bring it back down below a 5. So this is usually a pretty good guideline for you when you're doing activity, is that the range that we want to stay within. So some of those other contributing factors, if we have that tendency towards low mood or, we just don't want to be around other people, then again, this can affect our pain. It can be sources of pain in itself. It can really amplify pain that's already there, particularly if we've got, a sore knee or a sore ankle that's really bothering us. And again, that expectation that passive treatment rather than active will be the answer. And this is where some of that fear avoidance comes in, is that people don't want to be active because they think it's going to hurt. And so they think, the stuff like the massage, the physiotherapy, the chiropractor, where we're doing the hands-on work, is going to be the answer. And yeah, there's lots of stuff we do. We can give temporary relief. But I mean, you talk to any of the researchers, you talk to physicians, the physios, the chiropractors, massage therapists, we need to have the active component as well. Any of the hands-on parts of it, will usually give us temporary relief. Sometimes we can get a little bit more than temporary, but we need to have that active component as well. And I'll show you in a few minutes why we need that active component. So inflammation, the best visual I always tell people about with inflammation is that inflammation is a lot like Jell-O. When we're moving, it's nice and fluid, it's there, but it doesn't really cause much for restriction. It moves around quite well. When you stop moving is when it really starts to create issues, and it'll really start to gel and firm up. And that's why when you get up first thing in the morning, everything's so stiff. When you've sat for a couple hours, we're going to have a break after my talk here. Everybody's going to be a little bit stiff from sitting so long. It's because of that gel effect where that inflammation starts to gel, everything becomes a little bit more stiff. So what this can lead to is it's going to lead to some tightness. That can be either tightness within the joint itself or the muscles that surround the joint. If we're prolonged rest, then can lead to weakness. If we're not using the muscles, they're just going to get weaker. It's that use it or lose it philosophy. So if we're doing too much rest, then we're going to lose that strength. And in particular with the cartilage aspect of it, if that cartilage isn't loaded, then it's not going to get its nutrients. That's how that articular cartilage in the joints gets its nutrients, is to actually have load going through it. And again, I'll show you that here in a minute. That articular cartilage, that was that white lining on the bones. Basically, it's a sponge, or probably more accurately, a series of a bunch of little sponges within there, and that's how it gets its nutrients. Cartilage doesn't have blood flow through it. It has to get its nutrients in other methods, and that's where the sponge mechanism comes through. So, in particular, osteoarthritis is often described as wear and tear. There's been a real push the last few years here to start to get away from this mindset. It's a little bit of a shift, because it's a little bit misleading. If it was purely wear and tear, then why wouldn't it be equal on both sides? Okay, we know with osteoarthritis there's a huge genetic component to it. Previous injury has a large impact. We're starting to see with young athletes, even some of these kids that have had, for example, ACL injuries in their teenage years, some of them you can see some of the early signs of osteoarthritis in their around 20 years old or early 20s. So it's not an old person's disease. There's many people out there with osteoarthritis at all different stages that are quite a young age as well. And so what osteoarthritis needs is that cartilage needs movement to stay healthy. And again, we'll talk about how that works here in a sec. What happens within the joint is our body is constantly breaking down and rebuilding itself. And this happens with all our tissues, bone, muscle, cartilage. So within a healthy joint, we have that nice equal balance of degeneration and regeneration. So in osteoarthritis, it tends to affect the cartilage more. So as our body starts to degenerate that cartilage, then the new cells, and they're the chondrocyte cells, regenerate the cartilage. Rheumatoid arthritis, similar type of thing, tends to affect the bone to more of an extent, where again, that bone starts to break down, and then the body tries to rebuild the bone. So now what can happen with rest is that we start to lose that balance, that we start to get more of the degenerative aspect of it versus the regenerative aspect. And so the body starts to break it down faster than we can rebuild it. Same thing happens with osteoporosis, with bone density. The body breaks down the bone faster than it can build the density back up. So what will happen in osteoarthritis, that cartilage will start to thin, eventually it'll crack, and then as it disappears, we get that proverbial bone-on-bone aspect with it. And so as I mentioned before, the cartilage needs that load to actually regenerate it. It needs that sponge mechanism. So if we look at this here, we have the blue aspect there, that's that articular cartilage. As the joint compresses, the fluid gets squeezed out of the cartilage, much like a sponge. You push a sponge down, the fluid comes out of it. If you let the pressure off that sponge, then it can soak up the fluid again, and it can soak up those nutrients that it needs. And so as we do that with our load-bearing exercise, it can gain the nutrients, squeeze it out. Gain the nutrients, squeeze it out. And like I said, there's a whole bunch of little sponges within that cartilage. As the cartilage starts to wear down, then there's less of these little sponges in there. They're called proteoglycans. And what we found with exercise, that as we can do, particularly the load-bearing exercise, it increases the amount of proteoglycans inside that cartilage, and so we have more sponges. The tricky part is that we want something fairly low impact. If we have too much of a force or too quick of a force, it's not going to be able to soak up the nutrients fast enough. So again, think about a sponge. If you push it down really quick and let go, it's not really going to soak anything up. It needs that little more graded movement to it to give it time to be able to soak up those nutrients. And that's where the low impact activities tend to be a little more effective, so that we can get those nutrients into the cartilage that it needs. Now this graphic is taken from something called the GLAD program. It stands for Good Life with Osteoarthritis. It was originally developed in Denmark. They've just brought it to Canada within about the last 3 years, and there's more and more centers opening up across the country here now. It's a 6-week structured exercise program, mostly geared towards hip and knee arthritis. And the pyramid they base it off of is that at any level of treatment of arthritis, we have to have education, we have to have exercise, and we have to have weight control. Notice I've said weight control, not weight loss. Okay, and I'll expand on that here in a few minutes. If we need to go to the next level where we have pharmacological management with some of the medications, we still need to have that base level. We still need to have the education, still need to have exercise, still need to have weight control. If it gets to the point where we actually have to consider surgery, like a joint replacement, again, we still have to have education, still have to have exercise, still have to have weight control. There is some surgeons, for example, won't even do a knee replacement unless somebody loses a certain amount of weight, for example, because they just know the success isn't going to be there. We have to have these pillars, these 3 pillars to be successful. So like I said, weight control is all about not just weight loss. The key here is that with the research that they've done, they found that even a 5 to 10% weight loss is enough to reduce pain and improve function. The really, really important aspect of that is that it has to be maintained. It's one thing, losing weight is easy, keeping the weight off is the hard part. And that's where this becomes so important is a lot of people will look at it as, I have to lose 50 pounds. It's like, no, you don't. 10% of 200 is, 5% of 200 pounds is 10 pounds. If we can lose just that little bit of weight and we can keep it off, then we're going to reduce the pain levels, and chances are we'll have a higher level of function, and it's certainly going to be a lot healthier for that joint. It's going to allow that sponge to accept that fluid easier because it's not going to have as much load going down through it. So what do we do for exercise? Different types of exercise. There's cardio exercise, also called aerobic exercise. General recommendation is about 150 minutes a week. This could be broken down. For example, if it's 5 days a week, we would do about half an hour per day. Doesn't have to be half an hour at a time. Can be broken down into 10-minute segments. We could do 3 10-minute segments throughout the day. We're still going to get the same benefits out of it. As I mentioned, it's got to be low impact, needs to be repetitive so that we can create that sponge mechanism. How hard should we work? We always want to be looking for a moderate intensity. Moderate intensity is about somewhere between 2 to 4 out of 10, where 10 would be working as hard as you possibly can. With cardio exercise, often we'll use the talk test. So we're going out for a walk. We can still talk to the person beside us, but we couldn't sing to them, if we can sing in the first place. So that gives us an idea of how hard we're working, that we have some exertion where we're not to the point where we can sing, but we can still talk to that person that's next to us. So some examples of this, going out for a brisk walk, some cycling, dancing, yoga, mowing the grass, heavy yard work, all kinds of others. Those are just a few examples of moderate exercise. So vigorous exercise, if we're going beyond the moderate would be to the point where we can't really talk. You're sort of gasping for air as you're trying to talk. And that's when we're getting into that vigorous range, which, depending on what we're dealing with as far as type of arthritis, can be a little bit too much. And definitely not, if you're just beginning an exercise program, we don't want to start out at that vigorous level. So different benefits, improved heart and lung function. We talked about how it can improve the joint health. Cardio exercise is one of the best ones for that weight control. Weight control often is all about calories. If we burn more than we put into us, then we're going to get some of that weight loss. Helps with sleep, which in turn can help with some of those central pain mechanisms we talked about. The more sleep, the more rested you are, the better the mood and the cognitive aspect of it will be. Improved bone density. Anybody who's got osteoporosis or osteopenia as well, we're going to get some benefits there. We talked about the mood and just the ability to manage stress. Next type of exercise is strength. We want to look with strength exercises. We want to make sure we're doing at least a couple days a week. We'd go up to as high as 3-4 days a week is probably lots. Strong muscles take pressures off joints. As the muscles get stronger, they create a little bit of a hydraulic effect, and it can take some of that pressure off the cartilage. Pain can often inhibit strength. One of the early precursors of osteoarthritis we'll find is that strength can decrease as much as 20 to 40%. For example, in the knee, with osteoarthritis to the knee, a lot of times we'll find that the quadriceps are quite weak before the knee even really starts to get painful. And that'll be a big one that we start to work on, is the strength as well as the control of the knee. So a particular type of strength training is neuromuscular training, or NEMX is the acronym we'll use. So this helps improve the control of the joints. We had those ligaments that were a bit too loose, those bones can slide a little bit, so now we can use the muscles to try to control that. And there's different types of exercises or different ways we'll look at an exercise to work on that quality of movement, not necessarily how much of it we're doing. Like I said, it's all about the control of the movement. And this picture is a good example of it. On the left, you can see everything's nice straight line. His knee is right over top of his foot as he's going into a sort of a partial squat. On the right, the knee is really buckling in, and that starts to create a lot of extra strain on those joint tissues, and including the ligaments. And so we really want to work on that alignment and that control of the joint. People often ask me, what's the best time of day to exercise? The answer is whenever it's the best time for you. It's going to vary a bit from person to person. Usually it's not the morning, especially with arthritic conditions. A lot of us are quite stiff and sore in the morning, so morning tends not to be the best. Following medications is often good. That's when pain levels are less, or if we've used heat or cold to modulate some of that pain. So we want to do at least one set of 8 to 12 reps. Ideally, we want to do 2 to 3 sets. The resistance can be a lot of different types of resistance, weights, resistance bands, body weight, lots of different ways we can do it. Even daily activities can be used, gardening, snow shoveling, for example. There's group exercise classes like the GLAD program that I mentioned. A lot of the benefits, very similar to the cardio exercise. The joint health, again, we can help with the weight control. Balance is a big one, and that comes back to that joint control, is the balance and coordination, as well as some of these others. Flexibility, again, best done when the joints are warm. Everything's just more pliable, it's more elastic. So if we've had a hot shower, a hot bath, or we've gone for a bit of a walk first, then that's the best time to do flexibility exercises. A couple, 3 times a day. This will vary a little bit as to what stage of the condition you're at. With an acute flare of rheumatoid arthritis, for example, we'll do more often per day, but we won't go as intense. So by going more often, it keeps the joint from stiffening up so much, but we don't stretch it. We just take it through its normal range of motion. As a general rule, we want to hold these stretches for minimum 10-15 seconds, or that'll often correlate to 2 or 3 slow breaths. A lot of people have a tendency to hold their breath with stretching, so we'll teach it as a breath instead of a time to hold. And we always want to go to a stretch, not to pain. As soon as it hurts, the muscles are going to fight that stretch. So the flexibility needs to be specific. Some of these joints might already be a little too loose, because of some of that ligament laxity. This is a picture of an x-ray of a hand from rheumatoid arthritis. You can see how those bones aren't lined up so well anymore, and that's because of those ligaments and the capsule around the joint have really been affected, and it's allowed those bones to shift. That's a pretty severe picture, but I think you get the picture of how it can really affect that alignment. So again, flexibility, lots of benefits, very similar to the aerobic and the strength exercise. Big key here is that if you get pain with exercise, don't just stop. We want to modify instead of stop. We saw what rest can do to a joint. We have lots of options if we're getting pain with exercise. We can reduce how often you do it. We can reduce how intense you do it. We can do it in shorter chunks. We can do different exercises. Instead of walking, maybe we look at something like cycling or aquasize. And that's where, physiotherapists come in. That's our expertise is to help you what type of exercise is going to be most beneficial. As I mentioned before, we want to continue moving the joint, not necessarily stretching it, making sure we have a good warm-up and a good cool-down so that we give that joint a bit of a ramp-up time so we're not going hard at it right away. And we always want to be at that comfortable pace. If it's the cardio exercise, we want to be able to talk while we're doing it. With strength, we want it to be challenging, but within reason. It's got to be doable, and we can maintain technique through all the repetitions we do. So there's our scale again. With arthritis, there's pain. There's going to be pain in almost all cases. Some pain is normal. We have to keep it at that reasonable level. If it's that 0 to 2 range, great. If it's 2 to 5, we start to monitor it a little bit more closely, but we want to try to stay out of that 5 to 10 range. So when should you talk to somebody? When should you talk to the doctor? When should you talk to the physiotherapist? If it's starting to become sharp, not just that kind of dull ache, but if it's getting sharp or stabbing, if you're limping more than you normally would, if it's not settling back down within about 24 hours after exercise, if nothing's relieving it that usually does, for example, medication, ice, heat, use of a brace, those sorts of things, if you're starting to notice those joints are getting more swollen, more red, then again, we want to get it checked out, make sure there's not something else going on in there. Ice is a great source of pain relief. This is one of my favorite cartoons. We use this on our Facebook page every once in a while. Ice is a great painkiller. There's some debate out there in the literature right now as to how much anti-inflammatory effect that it has, but it's a great analgesic or painkiller. So just in summary, we have nociceptive pain, can be mechanical or inflammatory. We have that peripheral neurogenic pain where we get some of the peripheral nerves producing pain when they're not supposed to be. We have the central mechanisms, the brain and spinal cord that can affect it, as well as many others like autonomic, neuroendocrine, et cetera, We know that rest can lead to stiffness and weakness. Treatment-wise, we want those 3 pillars. Education, got to understand the disease and what's involved with it so that we know what to do with it properly. It's different from the different types of arthritis. Osteoarthritis is different than rheumatoid arthritis, which is different than lupus, which is different than gout, and that's where working with your physician and your healthcare providers can help with that. Sort of our 3 main types of exercise, the cardio, the strength, flexibility, and the big thing is don't stop completely. We want to modify instead of stop so that we can help maintain that joint health, keep those joints lubricated as we need to. So again, thank you guys for allowing me the opportunity here today, and I'd be more than happy to answer questions anybody may have. Sorry, I think they got a microphone there that they're just bringing around, just so the folks on the webcast can hear as well.
I don't know if it's on. Thanks, you're very understandable. I'm wondering if you could speak a bit to bursitis and also hypermobility, which is a fairly undiagnosed condition that a lot of arthritic people have.
Yeah, bursitis can affect many different areas in the body. Basically what a bursa is a bursa is just it's a little sac that has fluid in it. We have them all over our body. Their main purpose is to prevent friction. So they'll often sit between a tendon and a bone, or between a muscle and a bone, so that the muscle or tendon doesn't rub on it. And bursitis normally has fluid in it. Bursitis is when we get too much fluid, or we get that inflammatory process within it. So first goal of treatment is to settle down that inflammatory part of it, because if it does get to the point where it actually swells, then same idea. It starts to take up too much space. For example, in the shoulder, there's just a very small space where the rotator cuff goes through. If that bursa takes up too much space, then that rotator cuff tendon is going to get pinched and starts to create other pain. We can start to lead to tendonitis type pains. So any of the anti-inflammatory measures usually work quite well for bursitis. Some of the NSAIDs or the over-the-counter anti-inflammatories. Again, ICE is a little bit debatable as whether it's just an analgesic effect or a anti-inflammatory effect. Some of the bigger bursa, like in the knee, for example, compression works really well using a tensor bandage or a knee sleeve. And so in the physiotherapy world, those are usually the directions we'll go with it. First off, hypermobility. Some of us have different forms of what's called Ehlers-Danlos syndrome, or where all the joints in the body move a little too much. These are the people that we refer to as double jointed in a lot of cases. Or there is different disease processes that can lead to the hypermobility. With hypermobility, the big key again is that control, is that we've got to be able to train those muscles around the joint to control that joint movement so that the joint structures aren't moving too much. Because if we don't have that control, then things like the ligaments and the joint caps are going to get too much strain on them. They're going to hurt. They're going to get inflamed. And so we have to be able to create that muscular control by those muscles going across those joints.
How do you work through fatigue for exercise? Because I get home from work and I'm exhausted. I can't do anything more.
Yeah, and that's a big one. We get that question quite a bit in our practice. And so usually what we'll try to do, especially as an initial strategy, is to work it in throughout the day. So for example, an easy one with walking would be, maybe we park a little bit further in the parking lot than we normally do. So we walk, a few hundred feet more than normal, and that increases our walking for the day. And that kind of goes back to that you can do it in little chunks, those 10-minute chunks. Because for a lot of us, it's hard to set aside that specific half an hour in a day to do it. Like you said, you get home from work and the last thing you want to do is be on your feet. And so with that, my best suggestion is to work it in throughout the day. Some of the flexibility exercises we can do at our desk at work. I do them all the time while I'm working on patients. I'll get myself in a position where I'm stretching while I'm working on somebody. I said the cardio aspect, taking the stairs instead of the elevator, or parking a little further away, for example. Strength-wise, every time I say squats to somebody, everybody cringes, particularly anybody with hips or knee problems. But we can all sit in a chair. You have to squat to get into the chair. And so, we start to work it into the regular everyday activities where maybe we have you get up and down off the chair 2 or 3 times. And so that's where we can help you with those sorts of things, is to work it into the day where we don't have to set aside that specific time for doing it.
I just wondered about the stem cell treatment. I had read some that they're doing that for knees instead of operations.
Yeah, I know there's starting to be more and more research with the stem cell aspect. From my understanding of it, it's still a little controversial. There's a lot of anecdotal evidence that people say, had it done, felt great. Some of the early research coming out is that it doesn't really have that much of a better effect than not doing it. Like I said, I know it's still fairly on with some of the stem cell PRP injections are another one that they're doing. The stem cell injections can be very expensive. I know some folks going down to the States will pay as much as $5,000 to go get their knees done. So yeah, I mean, it's probably best to have the discussion with your physician, because they'll understand, what's going to be the best chance of success for it with you. Like I said, my understanding of it is that it's still a little unclear out there right now as to how effective it actually is. Perfect. Thank you guys very much, and hopefully you enjoy the rest of the day.
Impressing upon us how very important exercise is in helping to maintain healthy joints. Let's all thank Trevor for his great information. We will be taking a 10-minute break now. Please watch.